Tuberculosis is a chronic granulomatous infection caused by Mycobacterium tuberculosis. If the temporal bone is involved with tuberculosis, it is called tuberculous otitis media or tuberculous otomastoiditis. So, tuberculous otitis media is a rare cause of chronic suppurative infection of the middle ear and mastoid. It is rare and constitutes less than 1% of all cases of COM. Majority of these cases occur in Asia, around 55% of the total, and Africa, that is 31% of the total. Route of spread of infection to the middle ear can be primary or secondary. The primary form initially affects the middle ear and may spread to other neighboring structures by conjugating. In case of a pre-existing chronic middle ear infection, it passes through existing middle ear infection and also reaches the mastoid and middle ear through eustachian tube also. In the secondary form, it usually presents initially as pulmonary tuberculosis extending to the middle ear and temporal bone by hematogenous dissemination. That is hematogenous spread from the pulmonary focus. And the pathological forces are three types: acute phase, chronic phase and necrotic or caseous form. In the acute phase, there is congestion followed by thickening of the tympanic membrane and appearance of tubercles, that is a tubercle formation and multiple perforations. And in the chronic form, the caseation necrosis of the tubercles in the submucosal layer of the tympanic membrane give rise to multiple perforations which may eventually coalesce to form a single large perforation which is indistinguishable from that of a chronic suppurative otitis media. And the phase is slow and painless with perforations and also pale pink granulation tissue. So painless perforation with a pale pink granulation tissue. And in the necrotic form or the caseous form, it destroys the bone with a sequestrum formation. And the diagnosis, the clinician needs to have a high index of suspicion of the tuberculous otitis media in patients living in a highly endemic areas and also who presents with a otorrhea not responding to conventional treatment. So clinical features along with the bacteriology, histopathology and imaging. And in the symptoms, the primary complaints of the patient will be otorrhea not responding to conventional treatment, and also there will be severe hearing loss. And 50% of the patients will have an exposure to tuberculosis, and patients may have signs and symptoms of pulmonary tuberculosis such as cough, night sweats and fever, but number of patients may not present with all these findings. And in the signs, the most important one is otoscopy, where you can see multiple tympanic membrane perforation, and these multiple perforations are considered as hallmark of the disease, but it is very rare finding because the small perforations may coalesce to form a single large perforation, and through the perforation middle ear mucosa may appear pale or denuded. So the signs are painless otorrhea, multiple perforations, pale granulations and bone necrosis. In the third image, the blue arrow shows pale granulation, which is very typical of a tuberculous otitis media. And the hearing loss is initially it is conductive hearing loss due to accumulation of exudate in the middle ear and formation of granulation tissue and also tympanic membrane perforation. However, extension of the inflammatory process can lead to necrosis and erosion of the ossicular chain, the otic capsule, which will result in moderate to severe sensorineural hearing loss, or it can be a mixed hearing loss also. So conductive, sensorineural, or it can be mixed hearing loss, which is disproportionate to the clinical findings. And the diagnosis also from ear swab, culture and sensitivity, where a positive swab is seen in less than 20% only, and the ear discharge provide a very poor yield for positive culture. PCR in pus or tissue specimen is needed for confirmation of diagnosis. The most definitive way of confirming the diagnosis is by biopsy of the granulation tissue or the medullary polyp or tissue removed at mastectomy specimen. The microscopic finding of granulomata with caseous necrosis, epithelioid cells and Langerhans giant cells are the diagnostic modality. And in the imageology, CT temporal bone is a radiological investigation of choice. Plain mastoid or skull X-rays are non-specific. In the CT scan, you have to take a high-resolution CT scan of the temporal bone, both axial and coronal cuts, and here you can see erosion of the ossicles along with the destruction of the petrous part of temporal bone. And the other tests which aid in diagnosis are, one is a tuberculin test which indicate previous contact with the bacillus. However, it does not distinguish a patient from an individual infected by the agent. And also sputum examination for acid-fast bacillus will also help in the diagnosis, and even though it has very low sensitivity. In the treatment, an early treatment can prevent complications such as an irreversible hearing loss or a facial palsy. So, as immediately after diagnosis, start with an anti-tuberculous treatment, and surgical treatment modalities are also there. The indications of surgery are the presence of clinical treatment failure or complications such as a subperiosteal abscess, a facial paralysis, labyrinthitis or a central nervous system involvement. And in addition to that, mastectomy is performed when there is an association with a cholesteatoma. So, in all cases of chronic suppurative otitis media which is not responding to conventional treatment, you have to think think a possibility of a tuberculous otitis media which need a high clinical suspicion for diagnosis, and also the early treatment can prevent much of complications.